The following podcast is part of a certified educational activity titled Advancing Care for People Living with Moderate to Severe Atopic Dermatitis, The Future Looks Clear, featuring Dr. Jonathan I. Silverberg from George Washington University School of Medicine and Health Sciences in Washington, D.C., and Dr. Eric Simpson from the Oregon Health and Science University in Portland, Oregon. Access the entire activity and complete the post-test at peerview.com/KCX860. Downloadable slides and practice aids are also available.
Welcome to Advancing Care for People Living with Moderate to Severe Atopic Dermatitis. The future looks clear. Tonight's panelists are myself, Dr. Jonathan Silverberg, and Dr. Eric Simpson. So we're going to get started first by addressing unmet needs in moderate to severe atopic dermatitis and take a closer look at novel therapeutic approaches and targets.
All right, so I'll take over from here just to kind of get us warmed up. Jonathan, you know, and a lot of these are your data, that 9.6 million children in the United States are estimated to have atopic dermatitis. And, you know, you and I showed that 1/3 of those are probably more moderate to severe. So, you know, potentially candidates for systemic therapy, which we'll mainly be talking about today. We've also looked at several data sets, both of us, that shows maybe adult atopic dermatitis, with a lot of those being adult onset, actually, is about 7% prevalence in the adult population. And we know it's chronic, and it's often called intermittent waxing and waning. But for many of our patients with more severe disease, it's often a year-long constant disease. Although there are some patients who have those intermittent flares that are often seasonally related. And, we've shown for a long time now in trying to spread the word that your patients are suffering and they have a high burden of disease because of their itch, because of their pain, like you've shown, because of the lack of sleep. And that just affects everything, including mental health, work productivity, etc. So I think you and I have been on the podium trying to explain to derms and non-derms how important this disease is to patients and how important it is to potentially provide more aggressive therapy. All right, so you and I use a lot of these tools in clinical trials, and I know you use a lot of these validated tools in clinical practice, and both of us have made the claim that you need to understand the various domains of atopic dermatitis and the impact it has on patients. So let's just quickly go over what tools are out there that are validated, or some that we use a lot and some that you'll see in the literature. But then I want to hear from you kind of what you use in practice. So from my perspective, the EASI and SCORAD, those are great tools for clinical trials, but they're too cumbersome in clinical practice, I think, for your average dermatologist. The home group, which is our experts in outcomes, they recommend for clinical practice actually this PO SCORAD. So that's an app that a free app that you can have your patients download and estimate their own disease severity right there at home and kind of show you how they've been doing over time. So I feel like in Europe that PO SCORAD is used quite a bit. Other more patient-reported outcome measures are the POEM and the DLQI, which looks at symptoms and quality of life. I think these are appropriate for clinical practice, as did the home group. Do you agree with that assessment, Jonathan?
I do. I think PO SCORAD is a great measure to give you a lot of granularity, but it's a long measure. It's a hard one to complete in clinical practice, and it's hard to incorporate into electronic health records separately, because they have to do a standalone scoring app. So I think POEM and DLQI are just much easier. You have paper short forms, they're quick, they're easy, and they give you some really rich information.
Yeah, and I think that it helps you kind of better understand that patient who's in control, not in control, and whether you should escalate treatment or not. So yeah, I agree. I think if you're going to go for the easiest and the quickest ones, the pruritus NRS score, so 0 to 10, what was your worst itch over the last 24 hours? I know you validated what was your average itch over the last week, which is a valid measure, which would be another potential use to kind of get a more robust understanding of itch over a longer time scale. And then just a global assessment. So at the bare minimum, I would say do a global assessment like the VIGA, report mild, moderate, severe, clear, almost clear, maybe put an itch level on there, and that would be, I think you would learn a lot more than just what we normally document for our patients. And I do think I'd be remiss if I didn't bring up the control instruments that have been newly developed by both industry as well as non-industry, and they measure eczema control, and there are 6 questions that incorporate both quality of life and symptoms, as well as emotional impact, and they're called the Atopic Dermatitis Control Tool as well as the Recap Tool. Very similar, and I think those may be suitable for clinical practice as well. Okay, so once you've identified maybe how the patient's doing, are they in control or not in control, then you start thinking about, okay, how am I going to manage this patient? And this is a study that you were on, kind of trying to provide some clinically relevant advice on how to step up therapy, and so I would say from my perspective, under that mild column, that's basically skincare that we do for any severity. And that's the baseline. That's just your baseline discussion with the patient. And I would say even with my so-called mild patients, I kind of start at the moderate. And I start with mild or low to high or to medium potency topical steroids to clear the disease. And then I basically evaluate the severity of the condition based on how they respond to treatment. And if it goes away and they don't need many topical steroids from there on out, then that's fine. But if it comes right back, that's when I incorporate TCIs or non-steroidal therapies to try to keep it away. I don't know how you approach your patients, and if you put them in a bucket, or do you use treatment response as your severity measure?
I use a combination of both. I think I agree with your point. I think it's an important one that I start from the perspective of thinking of my patients as moderates, even when they're on the milder side, because the really mild patients, they're not getting into dermatology. Because they're able to manage with over-the-counters and stuff like that. So even our milder patients, if they're getting in to see us, are probably a little bit more to the moderate spectrum. But I do like to use some of the severity criteria. I think it's, of course, treatment response matters as you're thinking about stepping up therapy. But, sometimes I feel like patients are used, they may have a low bar because they've settled on poor disease control for 30 years. And so if I look at their skin and I say, well, by an EASI score, by an IGA, you're severe. I think we need to do more. They'll say, well, but today's a good day. I say, well, then I really know I need to step up therapy. So I do find that the severity scales really do give me more perspective and insight into what I should be counseling them about.
Yeah, no, that's a great point. We all have those patients who we're sitting there scratching our head, why don't they want to escalate treatment? And they don't know the new life that they could have. And so it's always a struggle with me inside my mind. I don't want to push therapy on people. I want them to be, be the ones that directing therapy. But and then for severe disease, I think that's, we know a severe patient when they walk through the door, widespread disease, very intense lesions, and then, not responding to topical therapy adequately is kind of how we define, and you and I've defined someone who's a candidate for systemics. And that's what we're going to be talking about today. So let's start talking about some of this exciting new data. We're going to start with the biologics. And I know this is a complicated slide. And so actually, since it's so complicated, I'm just going to turn it over to you, Jonathan,
Thanks.
If you don't mind.
Thanks for that. So, there's a lot here, and there's a lot for us to think about when we are approaching our understanding of the pathophysiology of atopic dermatitis. But the key thing is, as a clinician, when you look at this, you say, well, why do I need to know this? Why is any of this important? And the answer is because now we actually have new therapies coming that will target these different aspects of the immune system. So it's not this just theoretical consideration. It's really actionable in the very near future. So let's go forward and take a look at specifically the anti-interleukin 13 monoclonal antibodies. So first we'll start by discussing lebrikizumab. Now lebrikizumab, there's two anti-interleukin 13 blockers that are fairly far along. Lebrikizumab is actually a little bit further behind just in timing, and tralokinumab is a little bit further along, but it's a humanized monoclonal antibody that inhibits the signaling of interleukin 13 and it's not binding to a receptor, it's binding to that free cytokine and blocks it from binding to its receptor. We have several studies, but the most recent one is a phase 2b double-blind placebo-controlled study that looked at several different doses of lebrikizumab and different loading dosing approaches and higher doses from one of the previous studies of lebrikizumab. And what you see summarized here are the efficacy endpoints at week 16, which in general tends to be a fairly standard time point in the systemic and biologic trial space. But what you appreciate is that there are apparent dose-dependent improvements or reductions, I should say, greater reductions of the percent change in the eczema area and severity index from baseline at week 16, where that 250 milligrams every 2 weeks has the greatest reductions overall, and these are statistically significant improvements. And so, this is the primary endpoint for the study. One thing you always have to be careful about is how to interpret a percent change of EASI. So it's a little bit of a nerdy point, but it's not really showing you the deep response just in the way to look at this. So when you look at this, you say, well, it doesn't look like such a big difference between the placebo and the active drug. But when we look at some of the deeper endpoints like EASI 75 or EASI 90, I think that's really where we see that value and separation from the placebo. Before we move into tralokinumab, any comments on this, Eric?
No, I think it's important scientifically that blocking IL-13 alone versus the dupilumab that blocks IL-4 and 13 can provide you really nice results. I think a minus 70% reduction in EASI without topical steroid use or significant topical steroid use, I think that's pretty impressive. And that's kind of how I quote the efficacy to my patients. I think it's relatively easy to understand. So no, I think it's a very impressive results. I'm looking forward to the phase 3.
Absolutely. All right, so let's switch gears, and now we'll talk a little bit about tralokinumab. And here we have more data simply because we have the completion of multiple phase 3 studies. So it's a little further along in its development. So we have studies looking at tralokinumab monotherapy, which is what this slide depicts, that's just the Extra 1 and the Extra 2 study. And then we'll show you next data for combination therapy with topicals. Now, tralokinumab is fairly similar conceptually, but this is a fully human monoclonal antibody that binds to interleukin-13 as well, preventing the binding to the receptors. And the Extra 1, Extra 2 studies are 52-week-long randomized double-blind placebo-controlled trials that looked at a single dose of tralokinumab, which would be a loading dose up front and then a 300 milligram every 2 weeks versus placebo. And the data presented here are for results up to week 16. Of course, there's a separate phase of the study with even longer-term data. And what you appreciate is for both the proportion of patients who achieve this Investigators Global Assessment Score, or IGA score, of clear or almost clear, or for the proportion of patients who achieve the 75% reduction in the eczema area and severity index, that there are significant improvements in the tralokinumab arm compared to placebo. Now, when you look at the IGA clear, almost clear, for the Extra 2 study, it's a little bit higher than for Extra 1. But in both studies, they are statistically significant. When we look at the EASI 75, you also see similarly a little bit of a higher response for Extra 2 compared to Extra 1. And now we have some updated data from the AAD VMX meeting showing that that initial response is maintained at high levels at week 52, even without topical corticosteroid use, and overall that remained well tolerated over time. And that potentially, and this is a novel aspect of the study design in the second phase of this study, which we're not showing graphs for, is the examination of could you maintain this response with lower dosing, right, with an every 4-week dosing instead of an every 2-week dosing. And they were able to show that a very nice proportion of patients who achieved that response initially were able to maintain that with that lower dosing. So I think it's very interesting that we may even have some opportunities for dose flexibility or dose reductions. What do you think the value of that is for patients, Eric, in terms of just, the conversations that we have on a daily basis? Where do you think that the value is?
Yeah, no, I appreciate that that they actually did this clinically relevant kind of study design, because that's always one of the first questions I get is, when can I start, when can I stop it, or when can I reduce frequency once the disease is controlled? So it's just a very common question from patients, and you can imagine that it would improve cost by reducing it to every 4 weeks. You have to, you get to reduce injection number, which is nice for everybody, including in pediatrics, and then reduce exposure to medication. So it's always nice to get to the lowest possible dose in general to maybe reduce potential side effects. So I think it's really helpful information. It is impressive. I agree with you that out to 52 weeks, they can continue their responses if you have response early on, even without topical steroids. So yeah, thank you.
Sure. All right, so now let's talk a little bit about what kind of response do we get when we add on the topical corticosteroids, and that's was studied in the Extra-3 study. So across both dosing arms, whether it's the tralokinumab 300 milligram dose or the placebo, patients were allowed to use topical corticosteroids, and they monitored the amount of topical corticosteroids used throughout the studies. And what was seen was overall a similar pattern, with significant improvements in terms of the proportion of patients who achieve that IGA clear, almost clear, or the EASI-75 responses. But what was observed is that overall, a higher treatment response seen in this study compared to what was seen in the monotherapy studies that we showed you on the last slide. And this makes sense. We know that for many systemic and biologic therapies, adding on that skin-targeted topical therapy can really have a synergistic effect. And so I think these are important data because, it's a question that patients are going to ask us is, should I continue on my topical therapies or not? And, if the patient gets to clear, almost clear without topical therapy, they're going to be more than happy to never use topicals ever again. But for those who do well but maybe don't get to clear, this shows us that adding on topical therapy does add value and can really give an even deeper response for patients.
No, I agree. It reflects real world more closely. Interestingly enough, it's not synergistic when you add the topical steroid. It's just kind of additive because that kind of placebo-corrected effect size remains about the same as it did in the monotherapy studies. But
excellent point. Excellent point. Now, when we think about the long-term efficacy and safety as it pertains to tralokinumab, here we have interim readouts now for longer-term follow-up. And what you can appreciate when you look at these curves is that they're pretty much flat lines, plus or minus, right? And so that's what we want to see when we're talking about durability or maintenance of response. And what this suggests to us is that patients who do well early on can really have a good potential of maintaining that over time. Obviously, this has very important implications given, what, as Dr. Simpson mentioned earlier, for so many of these patients, it's not a waxing and waning disease. It's a, 52-week long disease, and patients may need chronic therapy. And this shows us that this may be a good approach for that chronic therapy.
I do think we should maybe just say one thing on safety, since I mentioned it on the IL-13s, that
sure.
I would say overall in general, and see if you agree, that it's very similar to the dupilumab safety data in terms of it's quite a clean profile with really only one important risk, which is conjunctivitis. You saw it in both lebrikizumab and in tralokinumab, but possibly at lower frequencies. But I think overall the safety profile looks really good for those anti-IL-13s.
I agree. And, one of the interesting and provocative questions that still remains somewhat unanswered is, could it potentially be even cleaner, even safer, right? You're targeting only one cytokine instead of two. Now, the safety profile for dupilumab is pretty good, so it's hard to beat in that sense, but it may be that there's lower rates of conjunctivitis. Maybe yes, maybe no, right? Time will tell. But, this is something that, safety for any drug that's going to be used potentially long-term is so important. And I think that's where the classes, both, and really it's true even for the next class that we're going to discuss, that where the biologics really often have major strengths is in the safety realm because of their targeted aspect of things. So excellent addition. Thank you. So let's switch gears. We'll talk about anti-interleukin 31 receptor alpha monoclonal antibody, and that's nemolizumab. Now, these are data from a phase 2b, 24-week long, so a little bit longer than some of the other studies that were shown earlier. Randomized double-blind placebo-controlled study looking at several different doses, 10 milligram, 30, and 90 milligram of nemolizumab. And this notably is a combination therapy study. So this is, in a sense, similar to that extra 3 study we showed you for tralokinumab. Right? This has the addition of background topical therapy across all treatment arms. And so what you're appreciating here, and these graphs are a little bit busier just because there's more doses to sort through. For changes in EASI over time, you see that all of the doses have some improvement compared to the placebo arm. But interestingly enough, not quite a clear-cut dose response, which is an interesting observation that we've seen even in earlier phases, and where what appears to be that clear winner is actually the 30 milligram dose of nemolizumab, and maybe even a little bit better than that higher dose of 90 milligrams. And we see this actually consistently across multiple endpoints, that 30 milligram dose appears to be that clear winner. Now, whether or not the 30 is better than 90 may be debatable, but the key thing is you don't need to add more than 30 to get that, what seems to be that peak effect. And so likely 30 milligrams will be sort of the dose to study for future phase 3 studies. But it raises some important points to think about. One is, the strongest effect that nemolizumab has really is on the itch component of the disease, as we would expect, right? Because it's targeting the receptor for what we would call the itch cytokine. But fascinating is that when we look at the efficacy even on lesions, now granted this is in combination with topical therapy, we also see significant improvements of the eczema area and severity index and a variety of other investigator assessments as well. So it's quite provocative that by targeting the itch, we can actually improve the lesions as well, although, we could argue, and this is something that I'll pose the controversial question to Dr. Simpson, but, where do you see the lesional improvement for nemolizumab so far compared to what we know about some of the existing therapies like dupilumab?
Sure, yeah, of course, it's difficult to compare between studies. There are different patient populations. But I agree with you. I think the strength of Nemo is in the itch reduction, very impressive. And so, whether that, I believe that pathway has anti-inflammatory effects when you block that pathway. So it's not just stopping the scratching makes the rash go away. It actually does have some anti-inflammatory properties. So I think if you have a so-called itch-dominant atopic dermatitis, and that's the number one complaint. I mean, it's the number one complaint for most of our patients. But if it's way out of control, this could be a good option. I think we have some data from phase 3 which are a little bit disappointing, and so I think we still need to understand the full utility of this drug with further phase 3 studies.
Absolutely, and I should just for context, I'm sure the audience doesn't care as much about industry development issues, but it's fascinating because it's being developed separately in Japan versus the rest of the world. And so what you're looking at is rest of world studies that have looked at some doses. In Japan, they studied a 60 milligram dose, which is perhaps less effective than the 30. There's still some questions about this. And a different target population in terms of the requirements for itch and severity and other aspects. So we see some differences where the results in this study look better than the results in the study that Dr. Simpson is mentioning. And this is exciting. We want to see what the next phase of studies teaches us about the different dosing issues and severity issues. It may work particularly well in those who are super itchy, but not so much in the less itchy patients. So this is something I think, stay tuned because we're looking forward to seeing more data on this. There's some interesting data as well. It's a unique population. The way the target population was designed for this phase 2b study was that they allowed patients with less severe lesions into the study, but had more severe itch compared to some of the inclusion criteria that, for the tralokinumab studies, for the dupilumab studies. So this is a post hoc analysis that I had the privilege of taking the lead on that looked at the subset of patients who did have EASI scores greater than or equal to 16 and also had the severe itch. So comparable population from a lesional severity standpoint to the dupilumab studies. And here, actually, what was seen was very comparable efficacy and in certain endpoints, maybe even better efficacy than in the overall population. So this suggests that, nemolizumab potentially could even be a contender in those with more severe skin lesions and not just those with more severe itch. But as we already discussed, stay tuned because there's certainly more data coming and we're eager to see them. Now, safety of course matters. As we already discussed, this could potentially be a medication that is used long-term in our patients. We want to know what safety looks like. So we still have some questions about that. Overall, the safety has looked good. But there's some questions about whether or not there may be some asthma signal there. So but it's not clear cut at all. So we definitely want to see more data, but overall, a very reassuring safety profile. Now, this slide actually depicts the trial data that Dr. Simpson was mentioning. And here, it's a little bit of a different cohort. First of all, it's a study done in Japan, which may or may not make a difference in terms of the underlying physiology, but it's patients with moderate to severe pruritus and an inadequate response to topical agents. So the way this is sort of positioned is more as an anti-itch treatment, not really addressing as much in the lesions, but looking at a very different dose at 60 milligrams. And with this medication, from what we can tell, dose matters. And concomitant topical agents. And so this is a study that was published in the New England Journal recently. And they found that there were improvements with nemolizumab compared to placebo with respect to itch, and perhaps less of a delta when we look at some of the changes and the improvements on lesional severity. But also over here, we see a positive study, but something that is maybe less of an effect size compared to what was seen in those studies done in the rest of the world. So again, stay tuned because this is a very exciting time to see what the future studies read out and what is the optimal dose and who are the right target populations for this drug. And so with that, I think we can take a pause on the slides and really open it up to audience question and answer. And we do have a few questions that are here. And so, I'll read out the first question. And if you want to take a stab at this, Dr. Simpson, please do. How do you modify the treatment of atopic dermatitis in pregnancy? I think this is a broad question that's a very valid one.
Yeah, and I think probably, I don't know if you believe in the rule of thirds, but I do believe that, probably a third of women get worsening of their disease, a third may get better, and a third kind of stay the same. And so, I think it is kind of pregnancy. I've considered a kind of type 2 state sometimes, and that's going to make atopic dermatitis worse. And I do think that a lot of these, many of these pregnancy related itch conditions that have various names are probably all variants of atopic dermatitis is my hypothesis. But in terms of how I treat these patients, for the moderate, I think for the topical is fine. You can still use topical steroids, and then, plus minus TCI if you have a discussion with your patient. But for moderate to severe, phototherapy, cyclosporin are both, with the help of the neonatologist or the high risk OB is helpful, and those could be possibilities. Short-term oral steroids could be a possibility for a severe flare. We published a case with dupilumab all the way through pregnancy in a very restrictive case. But I don't recommend until we have more information on the safety of biologics in general in pregnancy. So I have people come off usually and then try to maintain with phototherapy or topicals.
Excellent points. I agree with literally every single one of them. I would just add maybe two additional points for consideration. One, on the dupilumab side, there's now actually a pregnancy registry that is open. So, hopefully we'll have some information, real world information about it. But I would also say if you have any patients who are pregnant and on dupilumab, it may be a good idea for them to sign up so we can learn more. On the issue of cyclosporin versus oral steroids, I've had some interactions with a number of high-risk OBs with patients, and some of them have expressed concerns about using oral steroids in later phase, in the third trimester, because it has been associated with spontaneous abortion or preterm labor. And so some have expressed a greater degree of comfort with systemic steroids early on, because there's less concern in pregnancy, because there's less concern about teratogenicity, and then cyclosporin maybe in third trimester where you're at that point where teratogenicity becomes much less concerning and it doesn't have this potential impact on preterm labor. So that may be an additional consideration for us to think about. And so I think maybe we have time for one more question, and then we'll get to move forward and talk about the next aspects of data. I think this is also a fairly broad question, but are there special considerations for the management of children versus adults with these different biologic treatments?
Sure. I think surprisingly enough, the efficacy of these biologics are very similar in both adults and children. And so, maybe we have a higher threshold of severity before we feel comfortable to put a child on a long-term systemic therapy. But for me, there's not that much difference, actually. I want to help the lives of both sets of patients. And who knows, with further data, we might understand that treating early can maybe even change the natural course of either the atopic dermatitis or these allergic comorbidities. So I treat them very similarly.
Absolutely. And I think, I agree. I think with children, we're always a little bit more risk averse, and arguably rightfully so. But, one of the tricky parts, and a lot of times I think we get nervous about putting a patient on a systemic, agent. But, I remember having this conversation about a year ago with a parent that was really reluctant to get started on dupilumab in a child. And the child had not been in school for 4 months. Because of their atopic dermatitis. And so while we had to think about what is the long-term risk or safety concern of dupilumab, I just responded to the mom saying, well, isn't there going to be a long-term harm of not being in school for 4 months straight? And there was just this epiphany, like a light bulb went off. Oh, right. So we have to recognize that there is a degree to which this disease is so debilitating and so problematic for patients that it may even have progressive effects on patients' lives. We don't think of it as a progressive disease, but the truth is in some it can be in terms of its long-term sequelae. So excellent. So I'm happy to turn over the discussion of small molecules because this is a complex slide, so it's all yours.
All right, thank you so much. So we've just talked about biologics. Those are really working on the outside of the cell, binding to receptors, binding to cytokines. But now we'll be talking about small molecules, and those can usually penetrate through just about every cell and get to kind of cell signaling inside. So let's start on your top left. There have been studies looking at these small molecules that block itch. Either they block a neurokinin 1 receptor or mu kappa opioid receptors. These are all receptors and pathways that are important for itch in general. And I would say overall, these studies have been somewhat disappointing. They maybe do reduce itch somewhat. They don't really touch inflammation too much. And so we're not going to be talking about those today. Then looking at histamine, we know that H1, H2 blockers don't really seem to be effective in atopic dermatitis. I don't really use them for itch, and I think the data bears that out. They can help with sleep if you use the sedating ones somewhat, but they can have potential long-term side effects. But H4 receptor is an interesting target that maybe has more kind of affects the T cells more regularly and more reproducibly and can improve inflammation. And I have to say that the studies have actually been somewhat disappointing in that regard. So then we move over to my mentor was the first to kind of report that phosphodiesterase 4 was upregulated in atopic dermatitis and led to these kind of hyperactive immune cells. So it's really kind of a nice way to understand hyperactivity throughout the immune system in atopics. And there are topical PDE4 inhibitors that are showing response in atopic dermatitis. We did an investigator-initiated trial of an oral PDE4 inhibitor that showed about a 50% reduction in EZ and a reduction in itch, which was replicated in a larger phase 2 study. But it was not just getting patients clear, and the FDA endpoint for approval is clear or almost clear, which we could argue is probably too high of a bar, because I'd still have patients from that investigator-initiated trial say, I wish I could get that, a Premolast back for my atopic dermatitis because it worked on my itch and my severity. It just wasn't quite potent enough. So then we're left with the last category, which is really exciting, and these are 3 JAK inhibitors that block the signaling of cytokines. So it's not blocking the cytokine outside the cell, it's blocking what the cytokines are signaling towards the nucleus to then do their thing and transcription of pro-inflammatory cytokines. And so we'll be talking about 3 of these that are in phase 3 trials. They all block at least JAK1. And when you block JAK1, you're going to block a panel of cytokines that are important to atopic dermatitis. So you potentially could get higher efficacy because you're blocking more than just IL-4 and 13. Maybe you can get improved itch responses by blocking also IL-31 or GM-CSF, even with blocking JAK2 and pain and other potential improvements. But as you might expect, if you block more cytokines, you might potentially have more side effects. And I think we're seeing those, and we're going to talk about that balance of efficacy and side effects as we move through some of these phase 3 trials. Okay, so moving on from JAK inhibitors, we're going to start with abrocitinib. It's a targeted JAK1 inhibitor. All these JAK inhibitors are oral. There is a topical JAK inhibitor as well, but we'll be talking about from moderate to severe. We'll be talking about the oral ones today. And they all have had at 6 to 8 phase 3 trials. They all start with a so-called pivotal phase 3 trial of adolescents and adults, moderate to severe, similar criteria for the dupilumab, the tralokinumab, the lebrikizumab studies. So the populations are pretty similar. And I'm going to just point out like the key data, usually for the highest dose for each of these studies, because you're going to be bombarded with a number of phase 3, and I'll just kind of tell you what the main take home is for me, and then I'll have Jonathan chime in. So if you look at this, this is a 12-week study rather than 16. JAK inhibitors in general work quite quickly both on itch and on skin. And if you look at the far right column, you can see that in the highest dose, the responders, which is a clear or almost clear on the investigator global assessment, you can see 44% of patients at week 12 hit that endpoint. So that's very clinically relevant. I would say, within the ballpark of dupilumab at least. And we're gonna have a head-to-head against dupilumab, which is so helpful, and that'll be on a future slide. That's at the high dose. At 100 milligrams, 24% of patients achieve clear, almost clear skin, and these are statistically significant compared to placebo. EASI-75 responses are very nice, correlate with the IGA, so you're having dose-dependent improvements, very clinically relevant results, and this is kind of the baseline with no topical steroids. Any comments on this JADE Mono 1 study, Jonathan?
Yeah, I mean, these are very impressive data. The JAK inhibitors, particularly in their higher doses, really are setting the bar for efficacy. But of course, we have to have that balanced conversation around safety too. But these are impressive numbers that we haven't seen before.
And so this was the Mono 2. Then Jonathan was the first author for that was Mono 1. This is for Mono 2. Identically designed study. He copied my study design exactly, and pretty much identical results. So if you can see that IgA response, this one was a little bit lower than Mono 1, but close to 40% clear, almost clear at that highest dose. Those orange dots. And then you can see the 100 milligram tablet, just a little bit lower than that, but still statistically significant over placebo, very clinically relevant. So a replicative study that also hit all the endpoints just as we'd expect. So this next study I really like because it's so clinically relevant for us when we're trying to make decisions on efficacy and safety and which therapy to choose. So this was actually a head-to-head study of abrocitinib, both doses, the high and low dose, versus dupilumab. And this was had both 12 and 16-week time points. There was no official statistics at the 12 and 16-week time points in terms of the head-to-head, but I think we can get some good understanding of where these stack up in a very similar patient population. These patients were also allowed to use topical steroids. So I'd say that the key points here, the key data I would say is look at week 2 at this top graph. These are IgA responses, so clear, almost clear, the proportion of patients achieving that. And what you notice is that the orange and the blue are, that's 10 to 20% at even week 2. Those are the 2 abrocitinib doses. So and then the green bar is dupilumab. And these are the proportion of patients clear, almost clear. So what you can see is that you're getting this quick response in both your abrocitinib doses. So I think that is the benefit of the JAK class, is a very rapid response. And then as you move over time, you can see that all the proportions increase, and you can see that the highest proportion of patients that are clear is at the 200 milligram dose, just numerically, of abrocitinib compared to the 100 milligram dose. And you can see dupilumab kind of catches up to the 100 milligram dose, meaning the green bar is pretty similar to the blue bar. So I would say I kind of think about the 100 milligram dose of abrocitinib being similar to dupilumab in terms of efficacy. It probably works quicker. And then if you need even higher efficacy, I would say the 200 milligram tablet of abrocitinib gets you there. Is that how you read this study, Jonathan?
Exactly.
Okay. All right, great. So then this was a nice study that you can then look at comparison of safety and efficacy, and we'll talk about safety here in a second. So now some of these basic questions. So these were adolescents and adults, but what about just adolescents in general? So this is a study that only looked at teens, age 12 to 17, moderate to severe, looked at both doses, and I would say the take home from this one of 8 phase 3 trials is that teens do just as well, if not better, than the adolescents and adult populations combined, and with no new surprises. So when you look at these IgA proportion of patients achieving success in the 200 milligram dose, that's 46.2% of patients, and in almost 42% of patients in the 100 milligram dose. So really pushing these efficacy levels up in a large proportion of your patients. And then this is another clinically relevant study of abrocitinib. So this is a 52-week study that looked of over 1,000 patients. And what I like about this study is that I also feel like this is very clinically relevant back to our discussion of if you respond to treatment, can you step down? So like you showed in the tralokinumab study, can you step down to a lower dose and maintain your responses? And so after achieving clinical response in the induction period, so everyone got the high dose therapy, and that's kind of how I like to use oral therapies in general. I like to start high, get patients clear, and move them lower, and that's exactly how they designed this study. So once you induce with the high dose, patients who responded then were randomized to a low dose or continue at the high dose. And you can see here the number not experiencing a flare compared to placebo at week 52, 81% did not experience a flare if you're at the higher dose. 57% did not experience a flare if you're at the 100 milligram, whereas only 19% did not flare at week 52 if you're at placebo, of course. So what this tells me is that, maintaining at the highest dose is probably, if you want to guarantee you're not going to flare, you'd stay at 200. But for the majority of patients, you can step down once control has been achieved. And what I like about that is that it just minimizes exposure to drug over time. Any comments on this study?
I think it's a very important study because, we want to minimize cumulative risk and looking for risk mitigation strategies. Dose matters. And this shows that there's a subset where we could reduce the dose and potentially minimize risk. So I think it's an important concept, probably one that applies for all the JAK inhibitors, but we only have data right now for abrocitinib in this type of use.
Yeah, and let's hope that we get 2 doses, because this dose flexibility is a real advantage for JAKs, an advantage for patients and clinicians to kind of tailor that dose and that dose frequency to each patient and give them only what they need to keep them clear. And then this was an interesting sub-analysis that was presented just recently at the AAD meeting, and the point of this study was that they looked at long-term treatment in the open-label portion of this study called JADE Extend, and they looked at just the subpopulation of patients who did not respond to dupilumab. And if you look at this patient, you would think, oh, this is a very severe refractory patient, or maybe they're not going to respond to anything. Well, what this shows us is that even if you don't respond to dupilumab, so-called dupilumab non-responders, you still have a very robust response to abrocitinib at both doses if you do make that switch. So I thought this was another clinically relevant approach. Any comments on this, Jonathan?
Absolutely. I think this is something, these are, there's a lot of flexibility and there's a lot of, I think, versatility to the JAK inhibitors because of the potential robust effects, but also the speed. And so these different approaches, I think, are really helpful for trying to develop, give us data on how we can tailor, rather than just have some one-size-fits-all solution for everyone. How do we tailor therapy? And I think that's very important.
Yeah, no, this is super helpful. If you have a patient who has an inadequate response to dupilumab or a side effect, this is helpful for us to know that, yeah, maybe that switch could be effective for them.
Yeah.
And then I think for JAKs, because they block more cytokines or an oral therapy, we have to think about safety. We do know that in RA, they have black boxes for serious infection, malignancy, thrombosis. So this is an excellent paper looking at an integrated safety analysis of laboratory values as well as some rare important side effects that you can see with JAK inhibitors. And I would just say, looking at those laboratory values, there's a slight dip in platelets for some patients at week 4, but those often go back to normal, even staying on drug. So I think when I read this, and then looking at everything else, I think there's very little laboratory values that I'm concerned about when someone is on abrocitinib. I might check baseline labs and then maybe a CBC at week 4 just to make sure platelets haven't dropped. And about 5% of people or so can maybe drop their platelets at that point. But after that, it'll be interesting to see what the FDA recommends in terms of lab monitoring. Do you agree with that?
I do, actually, and because from what the data we've seen so far, it doesn't really look like these hematologic changes are happening delayed, right? If they're going to happen early on, and they tend to be pretty transient. But so you don't want to check it 6 months later because you would miss it. 4 weeks, I think, is a reasonable time point. And if they're clear, I think the big question we have is there any value in checking it at all afterwards? Or is it just a complete waste of healthcare dollars? So I think we need a little bit more data to guide the answer to that question.
Yeah, and I think we'll probably be checking a little bit more often, probably as we get comfortable with the patients and the lab values. And okay, and then moving to your right, so I'd say for all the JAKs, it's pretty consistent that there's a slight increased risk of herpes simplex, as well as herpes zoster. Serious infections have not really been significantly increased in any of the JAK inhibitors. So this was nice because we're starting to look at these rare events. What's the rate of rare events? And so we're looking at cardiovascular events. And if you look, we have to think about a number of events per 100 patient years. It's 0.18. That could be consistent with baseline risk. And so we'll have to start comparing these long-term risks. These are patients who have been on drug for over a year, thousands of patients. So we're talking, rare risk over a long period of time. And so we'll have to compare these to the general population or the general population of atopic dermatitis patients to get some sense of whether this is elevated or not. So, for example, the VTE rate, 0.3, that seems like, maybe those pulmonary emboli or DVTs could be elevated in this population. And when you compare this to some data in the general population, it's actually pretty close to the baseline. However, if you look at these data closely, all these VTEs are really only happening in the highest dose and not happening in the lower dose. So I do think that there is probably a dose-related slight increased risk of DVT. And so what does this mean to you, Jonathan, in terms of how you're going to pick your patients for a high-dose JAK inhibitor?
Yeah, I mean, it's a great question. I think it's a fluid one that we're still learning. I mean, I think there's no question that there's a subset of patients who are very severe, where as good as dupilumab is and other agents coming, we just need something that is maximal efficacy. And so, certainly for the worst of the worst, this is going to be, not just abrocitinib, but as a class, we'd be thinking about the JAK inhibitors. But I think there is value even in those patients who are not the worst of the worst, and even in those who are not systemic or previous biologic failures. But I think we have to be careful. We have to get comfortable screening for those VTE risk factors, because it seems like all of those cases had some either family history or personal history of clotting. So we just have to get comfortable doing what doctors do and taking a history and a review of systems. And I think, with some of this great data we've seen for abrocitinib with the regimen study, we now have potential risk mitigation strategies with dose reduction. So I'm optimistic, but I think we're going to, we'll play with it in the real world and find our way.
Yeah, agree. And some other potential risk factors you could ask about would be smoking, hypertension, or contraceptive use potentially. So I think we'll have to kind of pick our patients correctly, but these are such powerful drugs that change people's lives, and I've seen it in person, that I would hate to just say, oh, I'm never going to use this because they have a really rare risk of something, because I've seen them change people's lives. Now, let's move on from abrocitinib to baricitinib. So you might wonder, why is baricitinib dosed so low? So we just talked about 100 milligram and 200 milligrams of abro. Baricitinib is at 1, 2, and 4 milligrams, probably only going to be 2 milligrams here in the United States. And that's because it blocks both JAK1 and JAK2. It's not just JAK1 selective. And so JAK2 is important for things like thrombopoietin, erythropoietin. So you can have some blood count problems if you dosed it too high. So the point of this monotherapy study, meaning without topical steroids, was to do the identical design phase 3 trials, 16 weeks. And you can see, let's look at the 2 milligram tablet, since that's probably going to be what's going to be approved in the United States. And you can say about 12% of patients are achieving clear, almost clear, in both studies at week 16, statistically significant over placebo. But I would say a little more modest, it seems like, than what we see with the other JAK inhibitors. And then if you add topical corticosteroids, like we saw with other, like tralokinumab, for example, it does give you higher efficacy, as you would expect, and that's what's shown below. So moving on to BREEZE 83. So this was so there's multiple BREEZE studies. I'm just going to kind of give you the take home. And the take home for this BREEZE 83 study, which is a kind of a long-term extension, is you can look at those lines. They look pretty flat. And the point being, if you get a response, a good response at week 16, you're going to continue that out to week 68. Do you have any other comments on this kind of longer term data, Jonathan?
I think that's absolutely correct. It may be that not every patient responds initially, but this shows us that when they do, that they can really maintain that response over time. And it's a very important fact for us to know clinically.
Yeah, that's a really good point, Jonathan. And I think you were the author on a recent paper that I don't present here, but that just shows that maybe that this drug, if you want to get that high response rate, is best for patients that have less than 50% body surface area. So maybe that's where baricitinib would be used in the kind of the more moderate patients, and you can kind of tailor it that way.
Absolutely.
All right, so let me just quickly go through some of these BREEZE 80 studies, and just to kind of give you the take home. So in BREEZE 84, they took a population that was resistant or was not a good candidate for cyclosporin. So it's impressive. If you have a refractory patient to even cyclosporin, they can still respond to baricitinib. That was BREEZE 84. Moving on, and stop me if you want to make some comments, Jonathan. And then BREEZE 85, this was kind of interesting. So this was a US study, monotherapy, looking at 1 and 2 milligram tablets. And I have to say, this was different than those original the monotherapy studies for in Europe, in that, look at the percentage of patients who are clear, almost clear. I said earlier it was about 11% at the 2 milligram tablet. For some reason, this study found 24% participants getting clear or almost clear. So almost double at least the proportion of patients getting clear or almost clear. So why did that happen, Jonathan?
It's an interesting question, and it's always hard to look back at trials and know some of these differences. I think it's a little bit of a more diverse patient population in North America compared to other regions, with a larger representation, particularly of African American patients. So there may have been some differences in the demographics. Perhaps there's different even in terms of environmental factors and triggers and seasonality at the times that they enrolled. But regardless of the exact reasons, I think these are probably the most reflective data we're going to get of what to expect in North America as North American clinicians.
Yeah, good point. And when you get people clear, almost clear, as you would expect with most of the JAKs or all the JAKs, you're going to get really great results on your quality of life outcomes, on your symptom indices, and like I said before, you're going to get itch reduction within days. Okay, then moving on, the Breeze 87, very similar results, but this is a population where they added topical corticosteroids. So the safety and efficacy are similar, if not better, additive results in the proportion of patients getting clear, almost clear, when you add TCS, as you would expect. You just have to do the whole study just to prove it, so we can put that into the label and have dermatologists comfortable with the safety and efficacy of using this drug with topical corticosteroids. Now, again, safety is most important. I really appreciate that this integrated safety study has been published for baricitinib. And I would say the most important thing to look at here, if you look at the deep venous thrombosis or pulmonary emboli, at the 2 milligram tablets, you're not seeing any of the thrombosis. You're also not seeing significant cardiovascular events. And so I would say, and then if you look at tolerability, nausea, vomiting, they're quite low. And so I think potentially, and time will tell, but potentially this could be the best tolerated JAK because some JAKs, like abrocitinib, have some nausea in the higher doses. The next drug has some acne at the higher doses. Baricitinib seems to have fewer of those side effects, I think because it's a lower dose. So could it be the best tolerated, quote, the safest? Do you think it's too early to tell that and make that assumption, Jonathan?
That is my read of the data as well, but we need even more data, right? I mean, as long that we welcome, as I second your sentiments, we always welcome this kind of integrated safety analysis, but let's see what 2-year data and 3-year data and 5-year data look like, and we learn more and more as time goes on.
Right, and the truth is that this baricitinib, although it does have a very clean safety profile, still going to have a black box warning for serious infections, thrombosis, and malignancy. So, are you willing to take a slightly more modest efficacy given this black box warning from the drug? And I think that's it remains to be seen. All right, so that's abrocitinib and baricitinib. Now let's move to the last JAK1 inhibitor, and this is a JAK1 only, like abrocitinib. And it's called upadacitinib, and they've had 2 phase 3 trials, monotherapy studies. And if you look at the measure 1 and measure 2, the key takeaways, it's basically very significant for both doses, 15 and 30 milligrams, statistically significant compared to placebo. And if you look at the IgA responses in this monotherapy study, they are some that we've never seen before. So one of the studies hit 61% clear, almost clear at week 16, and we have not seen that with any other therapy. Would you agree that this is quite significant efficacy?
Yeah, this really seems to set the bar, probably the best efficacy we've seen in any drug, period, for atopic dermatitis. So very impressive numbers at the highest doses.
Yeah, and again, it's hard to make those claims without head-to-head, so we would love a head-to-head of the 2 JAK inhibitors that are closest. And I think it would be difficult probably to tell the difference between the 2. And then these are the kind of the perfunctory studies. So does it work also in topical steroids? And you can see the IgA clear, almost clear at the lower dose, 40% clear, almost clear, and then 59% at the higher dose at week 16. So replicated the monotherapy results in a TCS use study as well. And then these are results from just summarizing that with topical steroids, you hit all your endpoints, you improve your quality of life and your symptoms quite rapidly. And then fortunately, they have a head-to-head. This has not been published yet to my knowledge, but is this better than dupilumab? So as we saw, abrocitinib was able to, looks like numerically improve over dupilumab results, as does upadacitinib. So if you look at the higher dose of upadacitinib, and let's look at the EASY 100. So that's clear skin. 28% in the UPA treated group reached 100% reduction in their skin rash versus 8% in the dupilumab. So this study did show me that I think has higher efficacy than dupilumab, and it shows the promise and the power of this class of drug. Any comments on this head-to-head?
Yeah, I mean, this one, just to note, is looking only at that highest dose, which is a little different than the abrocitinib study we saw earlier. But these are impressive numbers, and they suggest that this could be an option, that may be more potent, but also maybe even for those who have dupilumab inadequate responses. Although we don't have those data yet for that kind of study result.
Correct. And then looking at kind of this combined safety analysis that was just recently presented at the AAD, and forgive us that these are not published data, so we're limited in terms of what can report. But here's that acne signal that I talked about. So in the upadacitinib 30, about 15% had acne. Do you have any comments on what could be causing acne that we see in the JAK inhibitors in general?
It's a great question, and I think it's one that we don't really have all the answers yet. It seems to be something across the class, but this one seems to have higher rates, high rates of acne with upadacitinib. But interesting, maybe, right, because it's hard to compare across studies, but maybe lower rates of headache and nausea and vomiting, right? So while we might be tempted to assume all of the JAK inhibitors are the same, they may parse themselves out with nuances not only in efficacy but in safety too.
Mm-hmm. Yeah, thank you for that comment. And like I stated before, there may be slight increased risks in herpes simplex, herpes zoster, but they're low in frequency. So most of these are all less than 1% in any of the treatment groups. So that's very reassuring for us, I think, as clinicians. Okay, so that ends my presentation on JAK inhibitors, and I believe we have a few more audience Q&A. So let me quickly look at these, and we'll try to spend some time addressing each one of these. So how concerned are you regarding the black box warning in the JAK inhibitors, Jonathan, for atopic dermatitis?
Great for the easy question, thank you. I mean, look, it's black box warnings are black box warnings, and sometimes these are common events, and there's rare events, and there's things that are modifiable and monitorable, and then there's things that are not so. We have evidence that in general, when you're dealing with medications that may be immunosuppressing, that dose mitigation and reduction, dose reduction can help. So we have opportunities. We've seen the data with JADE regimen for abrocitinib. The idea of dose flexibility might be an opportunity to really reduce some of those risks. But this is a new drug. This is a new class. We're going to have to get comfortable properly monitoring for risk factors for venous thromboembolism. It's a little bit new to us, right? We don't think about that much in dermatology. So I think there's going to be new issues we will have to deal with. But at the same time, as you pointed out, for a lot of these side effects, these are rare events, low frequencies in terms of the concerning ones. And we might use this in 100 patients and not see any of these side effects happen. So I think we have to put it into context. But at the same time, we don't want to poo-poo it either and pretend like it doesn't exist. And we want to be careful to really select the right patients who have that optimal risk-benefit ratio.
Yeah, great point. Yeah, thank you. And I think this is a good one to finish on. One more, and we'll finish on this. And it's basically, I'm going to combine a couple of these questions. But how do you identify patients who would benefit from these treatments? And are there markers or phenotypes? How would you decide who gets a JAK, who gets a biologic, for example?
I think it's such a loaded question, and there's we could spend another hour just on this. But I think, there's a lot of interesting work being done into biomarkers and stuff like that. And I hope one day we really get a great biomarker for this disease. We're not there yet, at least for something that you can use in the real world, in clinical practice right now. For me, I like to look at severity, but maybe one of the more important points that we didn't get to discuss too much tonight is the longitudinal course, the temporal aspects. Recognizing, as we talked already about, some patients have 365 days a year of bad disease. And then there are some patients who maybe have more intermittent disease, however large of a subset that is. You're not going to use a biologic in a patient who's got 1 month of bad disease a year, because the patient's not going to stay on 12 months of drug to treat 1 month of disease. So I think there's an opportunity for small molecules in general, and the JAK inhibitors might be great in that setting. And then when you get into the more chronic ones, well, I think all of them are potential options, and we have not really figured out just yet how to identify, the right drug for the right patient.
Yeah, I agree. And for me, I think patient preference is going to be a big consideration. Do they want an oral pill? Do they want a pill that they have potential ways to reduce dosing and dose flexibility, like you said? So for me, patient preference will be really, really important.
Absolutely.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peer Review Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerreview.com/KCX860. This activity is supported by an educational grant from Pfizer.